Welcome to the first bonus lesson in Power Up Endo's 90-Day Super GP. All right, so I got a super value-packed bonus stack for you. It's really going to complement the coursework that you've just completed, and it's really meant to accelerate and complement the entire course that you've now completed. So I've got lessons in here and topics that are extremely clinically relevant and are really going to help you in certain situations and when making important decisions in your general practice as it relates to endodontics en route to becoming a super GP. This first bonus lesson is all about relieving endodontic pain on a time crunch, because this is something that you're going to encounter on a regular basis, and I want you to know how to manage these situations in an extremely time-efficient manner so that you feel empowered to take on these cases and not just throw your hands up and send the patient out the door with a referral slip. That way you can increase your revenue, your patient satisfaction, your patient loyalty, because these patients are going to be so appreciative that you're going to be able to do something for them in a super time-efficient manner that they're going to be raving to all their friends and family about how wonderful you are, how much of a hero you are, and how much you help them in their time of need. So I'm going to do this in reverse, whereas in the Power Up Endo 90-Day Super GP course, we did the case demonstration first, and then we got into the didactic. I'm going to go over the brief didactic lesson because it really helps to complement the live case demonstration that you'll see shortly. So I really wanted to show you an image of a clock, because what you're really doing here is trying to get this patient into a state of being pain-free as quickly as possible, okay? Because oftentimes these patients show up as emergency patients to your practice and they're very disruptive to your schedule. And so the whole idea here is to do just enough to get this patient limped along until their next appointment that you're able to allot a nice hearty amount of time for. That way you can perform your full endo treatment. So that's the whole goal. And so you have to be able to relieve these patients' pain in a time-efficient manner so it's not disruptive to your schedule, and so you can still be that hero that I know you want to be. There's a whole host of different scenarios that lead to this patient ending up in your chair with an endodontic emergency. And so the most common ones I've listed here. So first we have the slow burn. So that patient that's had a little discomfort for some time and their episodes of pain have gotten more intense and have gotten closer together in terms of the frequency of pain, to the point where now they're having a ton of pain. And usually these patients have been putting it off for quite some time, maybe taking some Advil here and there to manage their pain, but they can't deal with it any longer. And just like I mentioned in the course, usually these are the patients that show up around 4 o'clock on a Friday afternoon, or maybe they call right around lunchtime on a Friday afternoon, and they need to be seen because they are dying in pain. And so you have to be able to deal with this. The next type of patient is the patient that just had a recent filling or a recent crown not that long ago, and maybe you warned them that the remaining tooth structure over the pulp was minimal and they might have a endodontic problem necessitating a root canal, and so you had an inkling or an indication at the time that perhaps they will need endodontic treatment, but you weren't sure, so you went ahead and proceeded with your restoration or your crown, and boom, just like clockwork, they started to have endodontic pain. Then we have the truly out of the blue patient. So maybe they had a deep restoration a long time ago and there was no issues, and then all of a sudden, bam, they're dying in pain, they have to be seen. Or maybe they had a traumatic injury. So nothing was wrong, they chewed on something they weren't supposed to perhaps, and they fractured a big portion of their tooth, whether that be a cuspal fracture into the pulp or whether that be a larger amount of tooth structure that was lost. So these things do happen. And then finally, we have the patient that's so swollen with an infection that's so severe that they look like a catcher's mitt. All right, you do not want to see these patients in your general practice. So if you're getting an indication that this is what the patient is going to be presenting with, if I were you, I would go ahead and just refer this patient to either an endo practice nearby or an oral surgery practice nearby. These patients are challenging and they're not going to be able to be dealt with in a super time efficient manner, at least not in your general practice. So I would encourage you to refer the catcher's mitts out. All right, and so there's some questions that you're going to want to try to answer when figuring out how to deal with these patients. So question number 1, is the pulp vital? Okay, that's important. So you want to try to gather that information over the phone. If the patient's complaining of a lot of cold sensitivity and some heat sensitivity, that might be the indication over the phone that they're having a situation with a vital pulp, which is the best because those are the easiest ones to manage in a time-efficient manner. You'll see this because this is what I'm presenting to you in the live case demo. So essentially what you're going to do for these patients is you're going to remove the caries that is most likely present. If there isn't, that's fine as well. And you're going to perform an IRM pulpotomy. This is the most time-efficient way to manage a patient that has endodontic pain from a vital pulp. It only takes about 5 to 7 minutes. It's a fantastic service to your patient, and it's the least disruptive to your schedule. And in case you don't know, IRM is a sedative filling that's a zinc oxide eugenol filling, and the eugenol inside of the material is what gives the material its sedative properties, and that's what's going to calm down an inflamed pulp. It's definitely going to get the patient limped along until you have an appropriate amount of time to perform your endodontic treatment. Because remember, the whole goal here is to be able to manage this patient's pain so that you can get them limped along to their scheduled endo appointment so that you don't feel like you have to immediately send this patient out your door to some form of specialist. If you want to do that, by all means, go right ahead. But I'm trying to tell you that there are ways to manage these situations that are not so disruptive to your schedule so that you can retain the patient as an endodontic patient in your practice. Because the endodontist, for instance, might be doing the same thing. So I know that in situations where I'm extremely time crunched and I only have, say, 5 minutes between appointments, I will perform this procedure, and it's very simple to do. And I'm going to be doing the same thing that you're going to be doing, where I'm going to be limping this patient along until I can get the patient in for full root canal treatment. Now, if the patient has a necrotic pulp that's causing this endodontic problem, it's a little more time involved. So you have to treat this patient similar to how we treat our 2-visit endo cases, like I presented earlier, where you're going to have to do full instrumentation and a chemomechanical preparation. So you're going to need to do all your hand filing, your measurement taking, your rotary instrumentation, your extensive sodium hypochlorite disinfection, and then you're going to be placing your calcium hydroxide. It's obviously much more time involved, so this might require anywhere between 15 and 30 plus minutes. So it's more difficult to squeeze this patient into the middle of your day. If you can do this in your lunch hour, fantastic. If you have to stack this at the end of the day, that's fine. But just realize that it's going to be, a lot more disruptive. So you want to gather that information over the phone as best you can. So if the patient isn't mentioning any thermal sensitivity, and also if the patient is mentioning, any kind of swelling, anything like that, there's a possibility that you're dealing with a necrotic pulp. Either way, you're going to gather this information immediately once you see your patient in the chair and do your diagnosis, but you want to try to prep as much as you can beforehand. Also, when doing your IRM pulpotomies, I'll discuss this in the live case demonstration, but you have 2 different formulations that you can work with. So the old-fashioned way has the liquid and the powder that you mix. It's actually what we use in our practice, but you need an assistant, or you need to feel comfortable mixing this material to a proper consistency. So the idea is to get the material to like a Play-Doh consistency, or even like a Cavit consistency, where it's workable, it's thick enough that it's workable, but it's not rock hard. And then once you put it into place, you'll burnish it with a moist pellet and you're good to go. And these restorations, the manufacturer says they will last for a year, but we're not going to be doing that. We're just trying to get this patient limped along, maybe a few days from now, or maybe a week, most 2 weeks from now. You want to try to get this patient in then. Also, the relief of pain that these patients will have is substantial, but it's not as good as doing full root canal treatment or doing full chemomechanical instrumentation and disinfection. And so it'll get the patient calmed down. It'll get the patient where they can manage it with some ibuprofen or Tylenol if it's indicated, but it's potentially not going to get the patient down to a level of 0 in terms of pain. But that's okay, because if they're at 100 now and you can get them down to 5%, that's a massive victory in the patient's eyes. Trust me. All right, so the next question number 2, is you determining whether the patient is swollen or not, okay? Because like I mentioned, if they're swollen, you have to do full instrumentation. It's going to require more time, so you have to prepare for that in terms of deciding where you're going to fit this patient into your daily schedule. You have to prepare different materials that your assistant will go ahead and prep for you. And there's certain situations where you have to manage the case differently. So if you have a large intraoral swelling, you may want to consider doing an incision and drainage, where you simply lance the area of the swelling to get some of that purulence out. That's going to really, really help in relieving pressure inside the patient's jaw. And you want to ideally get a lot of drainage through there, not just blood, okay? So you want to use your scalpel and you want to incise all the way down to the level of the bone and go ahead and perform your incision. And then once you press the areas around it, you want to get as much purulence out as possible, and you want to do a heavy rinse with sterile saline in the wound area to rinse it out. Remember, we're dealing with anaerobic bacteria when it gets to this point, and so we're trying to introduce as much oxygen and saline in the terms of flushing out the bacteria. And then you want to decide whether you're going to leave this tooth open or not. So in situations where we have a significant infection with some swelling and some purulence, especially upon access opening, I oftentimes, partially because these patients seem to always come around on a Friday, I oftentimes will leave these teeth open, at least over the weekend, so that the patient can have some semblance of a normal weekend and not be calling me multiple times throughout the weekend because they're still dying in pain. So remember, if we're leaving a tooth open, we're going to perform our instrumentation. We're going to place a sterile sponge. Obviously, this is after lots and lots of sodium hypochlorite. We're going to place our sterile sponge, and we're going to not place Fuji 9 or a Cavit temporary filling. We're just going to leave the sterile sponge in there. This way the drainage can occur through the porosities or the pores in that sponge material. And you'll need a sponge that's a little bit larger than you might normally use. This way, their patient isn't getting a ton of food impacted in there. If they do, it's not the end of the world, but in theory, the food impaction can actually close the site and thus create a situation where they're getting that pressure that's building up again. And then you'll reappoint these patients for a close appointment a few days later. And then question number 3 is, how tough is your patient? This is important because it's going to dictate really how you're going to manage the medications necessary to manage this patient post-operatively, at least from the emergency visit. So if the patient's tough, they can get away very easily with ibuprofen in a higher concentration. I like 800s. And I would recommend that you alternate your ibuprofen and your Tylenol every 4 hours. So they're taking their 800 milligrams of ibuprofen. 4 hours later, they're taking their 1,000 milligrams of Tylenol. That's the 2 extra strength tabs, obviously. And they're basically going back and forth between ibuprofen, Tylenol every 4 hours. Ibuprofen, Tylenol, ibuprofen, Tylenol. That is an extremely strong and reliable form of pain relief, and it's what I recommend the vast majority of the time. In the situation where you have a patient who is a lot more high maintenance, let's say, or is in a ton of pain, and you know that this regimen of ibuprofen and Tylenol alone is not going to manage it, then I would recommend you have them alternate with ibuprofen And instead of using over-the-counter Tylenol, you prescribe a narcotic, and they take that instead. So I will rarely go above the level of Tylenol 3, which obviously has codeine, but there are instances where I will actually recommend something stronger, like a Vicodin or maybe even a Percocet, okay? But remember, this is a rescue medication, so you want to let the patient know to use this only as a rescue medication, and they're going to use this in lieu of the Tylenol. So if they're going to do the alternating regimen, they're going to do their ibuprofen 800, and then they're going to take their Tylenol 3 or their Vicodin, or there's some form of their narcotic. But you're not going to have them take this in addition to the over-the-counter Tylenol, right? Because we're going to risk coming up to the maximum dose of Tylenol, which remember is 3,000 milligrams. And availability is super important for these patients. You want to be available for these patients to reach you in the event that they need to. So these patients need to be followed up with. So you may want to consider calling these patients the next day or maybe even the night of, and checking with them and making sure that they're okay. Sometimes patients, just knowing that you're available to them, will have them reach out to you less because they at least know that they have you if they need you. And that's especially relevant when you give your patient potentially your phone number or access to an emergency line that you set up for your practice. It's important to make the patient feel like they have access to you in the event that they need to reach you. So I give my cell phone number out to my patients all the time, and I don't get called very frequently. And remember, we're dealing with pain, so you would think that I would get called all the time, but it's actually quite rare that a patient will call. And some practices have an emergency line that will triage, obviously, to your cell phone or whatever phone number you ask them to call you on. And you want to let these patients know, especially if they're not going to be able to reach you, that if they get into a situation where their pain gets out of control or their swelling gets out of the control, especially on the weekend, okay, you may want to consider letting these patients know that if that happens, they want to go right to the urgent care or the ER, because you don't want the patient to be sitting there trying to reach you, or maybe you're on vacation or whatnot, and they can't, and the swelling is getting out of control. You don't want to be managing that scenario. So you want to let the patient know that they have access to some form of care in the form of an urgent care or an ER in the very rare instance that they'll get to that point. That's it. So that is all the didactics needed for bonus 1. And now we're going to get into the operatory and perform our live case demonstration. It's going to be all about performing an IRM pulpotomy on a patient with symptomatic irreversible pulpitis and symptomatic apical periodontitis. This is a very common occurrence. It's probably the most common emergency that I'll see, and it's what I will perform if I only have a few minutes, 5 minutes, let's say, before the next patient shows up, or if I don't want to go super late at the end of the day because my assistants have to take care of something. It's a great service to have, and it's a great tool to have on your tool belt in the event that you need to deploy these skills. I'll see you in the operatory.